All right, guys, we are going to get started with the part of chapter 46 that didn't get recorded in class today. So that is going to be covering the different causes of AKI as well as the different phases of AKI. So the different causes are going to be categorized into pre-renal, intrarenal, and post-renal causes. Pre-renal causes occur above the kidneys, before the kidneys, renal. Those are going to be things that affect the heart and that affect blood volume and vascular integrity and vascular composition. Intrarenal causes are going to be those things that directly target and damage the kidneys themselves. So it actually affects and targets that organ. Post-renal causes are going to be everything after the kidney. Post is after, renal, kidney, after the kidney. So those are going to be things that are affecting the ureters, the bladder, or the urethra. And most commonly, those are things that have an obstruction by nature. And we'll talk about that more in a couple slides. So as I mentioned, pre-renal causes of AKI affect systemic circulation and therefore decrease blood flow or perfusion to the kidneys. So while this decreased perfusion and blood flow is occurring, there's not any direct damage to the kidney tissues yet. However, as we've learned with like stroke and heart attack conditions, prolonged altered blood flow or prolonged low perfusion will lead to ischemia. And that's what can happen here. Pre-renal in and of itself doesn't directly damage the kidney, but prolonged decrease in blood flow will lead to damage to the kidney tissues within time. And then a sign and symptom of this is going to be oliguria from decreased blood volume. So oliguria means low blood volume, low urine output. And we're going to have low urine output because the kidneys aren't being perfused to function properly. And then this type of AKI, pre-renal AKI, is readily reversible with proper treatment. So this is going to be conditions that cause hypovolemia. So my trauma patients can experience pre-renal AKI pretty frequently. And our treatment for that is going to be to replace their vascular volume. In trauma patients, it's going to be with blood products usually. And patients that are dehydrated, it's going to be because they need more fluids. So yeah. And then with decreased cardiac output, that can be related to mechanisms of the heart not working properly. So depending on the cause of the altered heart function, we can do things like give inotropic medications to help with contractility of the heart, things like that. I mean, that could go on. We did a whole cardiac section. So just kind of piecing those things together. If somebody has cardiac issues, they can experience an acute kidney injury of pre-renal etiology. If the patient has decreased PVR, that's peripheral vascular resistance. We've also talked about this as systemic vascular resistance or afterload. So these could be if we have decreased blood pressure, so not necessarily blood volume, but decreased blood pressure from vasodilation. So different conditions that cause vasodilation, things like distributive shock, whether that's neurogenic, septic, or anaphylaxis. Those all cause a widespread vasodilation in the body and decreases afterload. So we could give vasoconstrictors or, treat that, vasopressors, treat the cause of that hypotension, and that would therefore help the peripheral vascular resistance. And then decreased renal blood flow for whatever reason. That can be because of the volume issues or the heart issues or just kind of anything else we haven't talked about yet. Any of those reasons would fall under pre-renal AKI. Intrarenal AKI are conditions that cause direct damage to the kidney tissue. So as it says, intra, within the kidney, these are going to be things that impair nephron function. So those directly target and impair kidney cells. The nephron is the functional unit of the kidney, and they are impacted and impaired by this. Causes of intrarenal etiology can be prolonged ischemia. Okay, sorry about that. So conditions that are going to fall into the category of intrarenal acute kidney injury are prolonged ischemia. So that's what we were talking about in the previous slide with pre-renal causes. So those are things that if we have prolonged decreased blood flow to the kidneys, it's going to lead to ischemia and then result in an intrarenal effect. Nephrotoxic agents, so those are things like certain antibiotics, and certainly contrast dye, which we talked about in a previous, well, today in class we talked about it, but we'll talk about it more in a minute. Hemoglobin released from hemolyzed red blood cells. So again, we mentioned earlier in this chapter, hemoglobin and myoglobin are too big to filter across the kidney on their own. They need a lot of fluid to help kind of pass them through the kidneys and get filtered out into the urine. If these conditions occur in a heightened way, like if there's an elevated amount of hemoglobin destruction going on, or of red blood cell destruction going on, to produce that byproduct hemoglobin, or if there's an increase in myoglobin in the blood, then this can cause an acute tubular necrosis. Then the myoglobin, as a review, is released from necrotic muscle cells. So those are going to be in patients like your found down patients, so patients who have been down for an unknown amount of time, whether that's, several hours to days even. It's very sad that that happens, but they experience an atrophy and damage of their muscles in those conditions. And the same thing can happen in like really high functioning, high practicing like marathon runners, or those who are inexperienced striving to be marathon runners. They can overwork their muscles and produce excess myoglobin. The issue with these things is they get trapped and caught up into the kidneys, and they cause an acute kidney injury or acute kidney failure because the kidney's not able to filter those out. So everything gets obstructed and backed up, and the kidneys can't function properly. Acute glomerulonephritis, which we talked about in the last section. The glomeruli is located within nephron cells of the kidneys. When they are trapped with immune complexes after whatever type of infection, particularly strep, then they cause obstruction of the nephron, and then proper filtration can't occur. Systemic lupus erythematosus has been associated with acute kidney injury of intrarenal causes. And then we talked about acute tubular necrosis. It is like the main cause of most intrarenal AKI. And the treatment is going to be, one of the first things we can do is review the patient's MAR, see if they have any nephrotoxic medications on their MAR, and advocate to get those stopped for a brief time until their kidney injury improves, or if we should, do we even need to be on those? Can we switch to a medication that's safer for their kidneys? And then contrast-induced nephrotoxicity. The big thing here is prevention. So we want to take a patient's GFR before we give them contrast dye, whether that's from CT or a procedure or whatever. We don't want to give them that contrast without knowing what their GFR is. If their GFR is normal, then they're fine to have contrast. If it's less than 60, most facilities are going to question the need for contrast in that patient. Will they still do it? Yeah, probably. Less than 30 is where most CT technicians and most radiologists are going to be very hard pressed to be convinced to do a contrast-induced scan on this patient, because there is a very high risk of acute kidney injury with these patients. If their GFR is very low, then it won't just cause AKI, it'll actually send them into CKD, or chronic kidney disease. So we're very aware of this. When patients get contrast dye, we usually want to flush them before and after with IV fluids to just help promote the excretion of that from their kidneys. If we were to still see a patient develop nephrotoxicity from contrast dye, then we can give them a drug called N-acetylcysteine, or we just call it acetylcysteine. Also Mucomist, it's the antidote for contrast-induced nephrotoxicity. It's given IV. Patients, this is actually also given to patients who have a Tylenol overdose. If you've ever heard of or been around patients in those conditions, this is the same drug we would give for that. And then we also educate patients on not taking their metformin for 48 hours after they receive contrast dye. Metformin is also excreted through the kidneys. And because the kidneys should be focused on excreting the contrast, that's how I kind of like to think about it. They need to do that task and that task only right now. They can restart their metformin in 48 hours. Post-renal acute kidney injuries are, in my opinion, the easiest to understand. They are simply a mechanical obstruction in the outflow of urine. So everything after the kidneys occurring in the ureters, the bladder, or the urethra that obstructs the flow of urine passing out of the body. So causes are going to be benign prostatic hypertrophy or prostate cancer. So enlargement of the prostate gland for males is going to block the urethra and keep them from being able to urinate completely. Renal calculi can certainly do that. We talked about that in the last chapter, how those stones can get caught in those ureters or the bladder and not be able to get past, or they can actually obstruct the ureter. And anything that obstructs the distal urinary tract is going to cause urine to stay backflowed up into the kidney. And when that happens, we have something called hydronephrosis occur, and that's where the kidneys are dilated with that excess urine buildup that it's holding on to, and that can lead to decrease in kidney function. Other causes are extrarenal tumors. So they may not be within the urinary tract system itself, but those tumors by proximity, closeness to those organs, can impede the function of them and obstruct that outflow. And then if you had a prolonged Foley catheter obstruction, that could certainly do the same thing because they wouldn't be able to have that flow of urine out of their body. You get the idea. If we identify this and relieve the obstruction within 48 hours, then complete recovery is very highly likely. Not a lot of damage would have occurred in that time that the kidneys couldn't completely recover. And it accounts for less than 10% of acute kidney injury etiologies. And the treatment is going to just be to treat the cause. So if it's BPH or prostate cancer, usually getting the prostate taken out, or given drugs that will kind of dilate the urethra and help the passage of fluid, things like Flomax you may have heard of. Get the stones taken out, catheterize them properly. If it's an extrarenal tumor, take out that tumor, put stents in if there's some kind of trauma to their ureters. Or if you just can't figure out what's going on, you can throw in that nephrostomy too. That's not going to be a go-to. That's going to be more of like a last-ditch effort, but it is an option. So now we're going to go over, what is it? Pre, intra, or post. These are also written in the notes section, but I'll discuss them briefly here. Hypotension is a pre-renal cause because of that decreased blood flow. So we talked about that back in our pre-renal slide. Hypotension, decreased blood flow to the kidneys, is a pre-renal cause of AKI. Bladder cancer, it's post-kidney. It's after the kidneys. It's in the bladder. So bladder cancer, overgrowth of bladder tissue, cell tissue, could cause an obstruction. That's a post-renal cause of AKI. Contrast dye, we talked about it, that's affecting the kidney directly. So is glomerulonephritis, that affects the kidney directly. Heart failure, hearts are above the kidneys. So that's a pre-renal cause because heart failure is going to cause a decrease in cardiac output. And so we need to address the heart failure in order to address the kidney injury. Aminoglycosides are a type of antibiotic that are particularly toxic to the kidneys. So we have to be very careful with our dosing in those patients. That would mean it's an intrarenal cause of AKI. Burns is a little tricky, but if you think about kind of the pathophysiology of what's going on in burn patients, they are losing, because of their systemic inflammatory response to the burn, they are going to have they're going to have a lot of capillary leaking going on. Sorry, I'm struggling to explain this. A lot of third spacing, so they're not going to have a lot of vascular volume. So part of our treatment for burns is to give them a lot of fluids to promote their kidney function, even though they sometimes seem like the Michelin Man or the, they're super swollen and third spaced. It seems counterintuitive to give them so much fluid, but we actually need to give them fluid to get it back into their vascular space. If they have decreased volume in their vascular space, then they're not going to be perfusing the kidneys appropriately. Burns, therefore, are a pre-renal cause of kidney injury. And then a blood transfusion reaction. What's happening in a blood transfusion reaction is the RBCs are becoming hemolyzed. So this is a intrarenal cause of kidney failure. If those are confusing you still, just shoot me an email. We can try to go over this a little bit more one-on-one, but just try to think about the location of where things are occurring, pre, intra, and post. And that should help you kind of keep things straight. When we talk about acute kidney injury, we're also going to delineate clinical manifestations, their symptomology, by 3 phases. And first of all, intrarenal kidney injury is usually a longer recovery. There's usually like a deeper problem going on if it's actually affected the kidney cells themselves. So they can have a longer healing process and recovery process than pre and post-renal injuries. But we're going to talk about 3 main phases of urine output, and in order, they are oliguric, diuretic, and recovery. And you do need to know these. These can occur in all 3 causes of AKI. If it's pre, intra, or post, they can experience these 3 phases. The first phase is oliguric. It occurs from 1 day to within a week of the onset of the injury to the kidneys, and it's defined as a decrease in urine output to less than 400 mLs per day. So not a lot of urine at all, and it can last up to 2 weeks to months. So it can be a decently prolonged experience here. The longer the oliguric phase has been associated with a poorer prognosis. So getting this nipped in the butt is very important. This is more common, the oliguric phase is more common to occur in, sorry, hang on just a second. Sorry about that. So the oliguric phase is more common to occur in pre-renal causes of AKI. Now, this is the, medicine is not black and white, so this is one of those gray areas. I would love if it was nice and simple and every single patient with AKI went through all of these phases exactly as they're laid out here. But it's actually more common in post-renal obstruction cases to see anuria or no urine production until the obstruction is relieved. And then in intrarenal AKI, we usually don't see an oliguric phase, but it totally depends on the patient and what the exact cause is as to whether we'll see this oliguric phase. And then the effects of oliguria are fluid retention. So if we're not excreting the urine out, then it's staying within the body, and any associated signs and symptoms with that. So that can be like crackles on the lungs, peripheral edema, JVD, etc. Metabolic acidosis will occur. Again, the kidneys are the metabolic part of your acid-base balance, and you'll experience an acidosis in this case. Hyponatremia because of the fluid retention. So we'll actually see a dilutional low sodium because of the retention of fluid in the body. We'll see a hyperkalemia or an increase in potassium because the kidneys aren't able to excrete it. You'll see kind of a theme in this PowerPoint here that anytime the kidneys are failing, they're not going to excrete potassium, and that can actually be one of the #1 causes of death from kidney injury is a high potassium resulting in cardiac dysrhythmia. So this is a high concern. Leukocytosis will occur in these conditions, which will increase their infection risk, waste product accumulation, as we've talked about. If the kidneys are not able to excrete nitrogenous waste products, then we're going to be retaining them. And if they accumulate, it can lead to neuro changes. Another thing that can lead to neuro changes, as we talked about in class today, is these electrolyte imbalances, especially sodium. Sodium can most certainly cause neurological abnormalities from confusion, altered mental status, agitation, combativeness, all the way to seizure and coma. So these can definitely be issues that we see with our patients in the oliguric phase. In the diuretic phase, so this is phase 2, this is going to be increased urine output to 5 liters or more per day. So an excessive amount. We went from one extreme to the next of urine output. Kidneys have recovered the ability to excrete waste products and to regulate electrolytes again, but they aren't able to concentrate the urine. So they're just letting everything go. The nephrons haven't regained the ability to reabsorb fluid as part of their job. So everything's getting excreted out. So we are at risk in this phase for hypovolemia and hypotension. And you can see how that can just send us into a vicious circle of recurring AKI. So we need to get on top of this, know that it can happen, and replace the fluid volume and get this under control. This can last for 1 to 3 weeks. And then the recovery phase. This is where I picked up in the PowerPoint today in class when we realized that it wasn't recording, but just to kind of reiterate here, our kidney labs will start to return to normal in this phase. So the GFR will increase back to normal, and our BUN and creatinine will decrease back to normal. Major improvement will occur in 1 to 2 weeks, but it may take up to a year for complete healing to occur. And then, so one of two things happen. Either the patient recovers and they get their kidney function back, or they don't and they progress to chronic kidney disease, which is what we're going to talk about next. I'm actually going to pause this here and restart with the chronic kidney disease. So this completely kind of closes out the combination of like what we missed recording in class and where we got to at the end of class today, wrapping up acute kidney injury. So I'm going to delineate it here, and we'll start with chronic kidney disease in the next video. Thank you.